So today we're going to be talking about moving upstream, looking into the causes of the causes.
Yes. And, it's something that I think you and I talk quite a bit about, the health services. We talk about virtual care. We talk about payment changes. But when it comes down to it, there's a reason why we need so much healthcare in the United States anyways. Why do people develop chronic conditions? Why do people actually seek healthcare so much? I think that's something that is worthwhile to talk about, and it's something that, actually really can benefit and be proactive in preventing healthcare conditions in the first place.
Exactly. I mean, if you just look at the tobacco industry, for decades, the tobacco industry knew the association between using tobacco products and causes of different types of cancer, all different sorts of cancer, not just lung cancer. And it was known for decades, but even during the time when that was known, the use of tobacco products was romanticized through Hollywood and all sorts of different advertising campaigns for decades, and it resulted in so many chronic medical conditions. I mean, even if you just, outside of just chronic lung conditions, if you just look at all the different types of cancers, if you just look at vascular diseases that were caused from just nicotine products alone, and I think about even where we're at right now, where society has gone past, the burning of the tobacco leaves to these e-cigarettes, and then what's the other, even the use of hookah, the tobacco, the hookah pipes.
I worked on, when I was still in school, I worked on one of the teams that was working for the FDA when they were first looking at, the effects of e-cigarettes on young kids in particular. And they found that a lot of the same sort of issues and tactics were being used by the e-cigarette companies to target young kids and to try and get them hooked on nicotine products at an earlier age. Those were new products, and they don't have a lot of the same chemicals from burning tobacco that cigarettes have, but they have to come with their own risks, and that addiction is still one of the major issues associated with using nicotine products, regardless of how it's delivered. And, I remember one of the studies was pretty substantial. It was done in California, and it was kids who were sort of in their teens and even before their teens, and it said about 30% of them had used a cigarette product in the past month. And I remember looking at that, one of the main studies upon which the FDA made some of their rulings, and I was like, wow, that's substantial. And it's obviously those types of things that actually lead to the formation of addiction, lead to the formation of disease, but there's a whole host of other ones that I think we don't talk about enough in this country. We talk so much more about, improving primary care, which is obviously very important for people who already have conditions. But what can we do? Can we be doing more to prevent conditions forming in the first place?
Of course. I mean, definitely from society as a whole. I mean, our society is still a very reactive society when it concerns health. The saying in America that it goes that you sacrifice when you're young, you sacrifice your health for wealth. And then when you get older, you sacrifice all that wealth to maintain your health or to stabilize your health. So our fee-for-service system encourages this reactive approach towards health in general. And that works with things like a sinus infection or something that you can feel the symptoms. But when you're talking about something like, say, hypertension, where 95% of the people have zero symptoms, when we think about the symptoms of hypertension, of blurry vision, of headache, of shortness of breath, or chest pain, that happens in less than 5% of people with hypertension. So in that case, waiting until you start having symptoms is far too late. You're only part of the small group of people who actually end up having the symptoms in the first place.
And I think that goes back to sort of where hypertension comes from in the first place. And one of the major drivers is diet and lifestyle choices by people in the country. And I think that goes back to sort of the cigarette argument, but there's also people who eat unhealthy food, and we as a culture kind of eat a lot of unhealthy foods that we shouldn't be eating that are detrimental for our health. And exercise and an active lifestyle is not as promoted, but those two items, if we were to increase the levels of activity, increase the levels of healthy diets, in the whole population, we would see tremendous benefit for the formation of chronic illness.
Yep. And actually in the chat here, we had Dr. Aisha mentioning about unhealthy food being cheaper. We have my brother Sahel talking about cheaper and addicting food is hard to kick. They bring up two major industries that immediately pop to mind. When we think about unhealthy foods, the first that pops to mind is just the fast food industry in general. The fast food industry, I mean, when you think about people finding value in a dollar sandwich or whatever the meals, actually the meals end up being quite costly. For one meal, you end up spending $6-7. That they don't realize themselves that they're already paying too much for the convenience of that fast food. But another industry I think about is just the junk food industry, and sort of tied back to the nicotine industry with the way that that tobacco was marketed and advertised. I think about the junk food industry and how words are thrown. Like you put a label of low calorie or gluten free, and people have this feeling that, oh, this must be something that's healthy for me, but the ingredients that are in there are not healthy for you at all. You know, and the same goes with the fast food industry and just causes of all sorts of diseases, cardiovascular diseases in general.
Right. And I think you and I are obviously big proponents of improving primary care and healthcare services in general. We see that there's a big need. We want to improve outcomes for patients who already have chronic illness. But if we were smart as a country, we would try to actually focus on some of these upstream factors like lifestyle behaviors, like diet, and trying to do things that actually incentivize people to live a healthier life in the first place without the need of medical services. One of the ways to do that is to improve health education across the whole country, to sort of prioritize the way that we teach health and how we talk about health in schools from a very young age. And obviously, we don't necessarily prioritize that as a country. So when we think about our overall healthcare costs over the next 50 years, we talk so much about value-based payment, which is really important to incentivizing and building better healthcare services. But I think what gets left out of those discussions is actually trying to invest in areas that have a much higher return on investment than medical services. We know that about 40% of health outcomes are attributable to social and economic circumstances. We know that another 25 to 30% is lifestyle and behavior. And so those two areas are much more impactful when you make investments there than even in medical services. And we certainly need to start having those conversations a little bit more robustly about what can we do to actually improve health overall in the country.
We need, and if you just look at the way that people can take off of work, the concept of taking off for work for your own wellness or for preventive issues, and if you can't do it for preventive or for wellness, then even at the earliest stages of you starting to have any kind of symptoms, people oftentimes will keep pushing themselves. It's almost part of our culture that you keep pushing yourself until you just cannot get out of bed.
I saw this thing the other day, and it was this little saying online that kind of resonated with me, which is, if you don't make time for your health now, you'll have to make time for your sickness later. And I think that we do not, as a society and as a culture here, do a very good job of trying to instill healthier habits and to instill sort of, or I should say, and to regulate industries that sort of propagate sort of bad healthy choices or that market in a way that kind of lead to bad health and lifestyle choices. But we talked about the social determinants of health last week, and you see this nice interplay. It's not nice, it's actually a very unfortunate, dangerous interplay between lifestyle choices and poverty, and lifestyle choices and food insecurity and homelessness. And one of those topics that we just brought up was that sometimes the unhealthy food is cheaper than the healthy food. And for people who are living on a very fixed income, like your patient population at ChenMed, or for people who are living on a fixed income their whole life, or a very low income their whole life, sometimes it makes more sense to get a higher calorie, unhealthy meal at a fast food restaurant rather than going to spend money on vegetables that don't fill the family up as much.
I've seen. I mean, it goes to the level of the convenience store. I see patients paying for if you just talk about diapers, the amount that our patients pay for a package of diapers from the convenience store is the same price as the mega stores like the Costco's and these wholesale clubs sell for the massive package of diapers. It's just it's for that convenience that the people are already paying too much. Sort of like what we talked about last week, that when we talk about 30 million Americans not having access to health care, they say, well, how can we afford to pay for all these Americans? And the response should be that we're already paying $10,000 for pneumonia that we could have been paying $10 for.
Yeah, I mean the effects of these upstream factors that we haven't been addressing are that we spend a whole bunch of money on it. We might be able to spend a little bit of money per person on improving health education, improving access to healthy foods, improving housing and stability for patients without houses or who are in unstable housing situations, and get return on investment because we prevent bad healthcare outcomes or costly healthcare outcomes at emergency departments or hospitals, and that money has gone into actually making somebody healthier, and also has been not spent on healthcare services. But the health system is not really incentivized to do that, and a lot of these other issues are not necessarily incentivized to change without sort of regulatory or sort of societal level action.
There needs to be. As a society, we should not accept that at least pre-COVID, half of all medical care in the country has been delivered in the emergency room setting. We should not accept that to be the norm. Especially now, I'm seeing over the last 6 months with COVID, how we've transitioned more, especially the full risk and the value-based care practices, and really across the board towards telehealth and telemedicine in general. I mean, now it's never been easier to get access to care.
Right. And I think one thing that we can receive from this virtualization of healthcare and improving access whenever needed is we need to start shifting the conversation from even medical services being reactive to trying to educate patients to focus on lifestyle interventions. And I know you at ChenMed, you guys do a really good job with this by training in motivational interviewing, sort of an intensive course to be able to help kind of encourage behavior change among your patient population, while even though it's still a little bit too late because of some of our societal choices and people already have conditions, you can still often see a lot of patient condition improvement and prevent sort of costly deterioration by incentivizing and sort of helping to positively impact behavior change in those patients. Is that right?
That's right. You cannot be a doctor coach or a lifestyle coach only seeing your patients 2 or 3 times per year. It is something that requires a long-term relationship. The initial visit needs to be one where you're investing in building that doctor-patient relationship.
Right. And so what does that look like, Faisel? Can you give me an example of when you've had a patient that may have been doing something in their diet or in their exercise lifestyle that you've been able to sort of make a positive change in? I
can tell you when I got in trouble when one of the first couple of weeks when I joined ChenMed. I had a diabetic patient whose A1C was through the roof, like one of these A1Cs of 11 or 12. And it was my first visit with the patient, and the staff told me something along the lines of, good luck, you're like his 3rd or 4th doctor. And I thought, okay, go meet the patient. I'm having the new patient visit with him. And he said, listen, I'm a diabetic. I'm supposed to be on insulin. I know what you're going to tell me. That, no sweets, no sugars, no sodas. Well, I drink, I can't remember what it was, 8 cans, 10 cans of Coke every day. And I'm not going to change. I'm not going to stop that, and I'm not going to start taking insulin. Before I even had a chance to even say anything to him. So rather than talking about anything related to his diabetes or his blood sugar in general, I started off by saying, you drink 8 cans of Coke every day? That's quite expensive, and remember, like in our world, all our patients are on Social Security. They're all Medicare patients on fixed incomes. So I started the conversation with him based on how much money he was spending on drinking so many cans of Coke. Didn't talk about the blood sugar. And he was blown away by that. And I suggested to him, why don't you start buying like a 2-liter bottle of Coke? I would imagine that it would be much more cost effective for you. And he replied back telling me, well, no, I enjoy the fizz. I enjoy the experience every time of a fresh can of Coke. So I said, okay, when do you absolutely need to drink this Coke? And he said, I got to have it with lunch and I got to have it with dinner. And I said, okay, so I'm okay with you having the Coke with your lunch and your dinner as long as you can promise to me that you will switch to seltzer water for the other times when you want to have a carbonated beverage, and you can use an artificial sweetener. And he agreed to that. And that for me was a huge win. We didn't talk about insulin. We didn't talk about anything else. We just talked about how to cut down drinking his Coke, because I knew that was a big push for him having this high A1C. Would you believe that, well, actually, when he went out into the waiting room, this is how I got in trouble. He went out in the waiting room, and Dr. Aisha would appreciate this. He went out to the waiting room, and he told the entire waiting room, that doctor over there told me that it's okay as a diabetic to drink Coke every day. And the center manager came to the back of the clinic saying, Doc, I'm not no doctor, but I don't think that it's a good idea for doctors to be recommending diabetic patients to be drinking Coke. And I told him, I said, but that's the first step, because now he knows that we can have this conversation. And believe it or not, within a month, I saw him back again, and he had stopped drinking Coke altogether on his own, because he found that he enjoyed the fizz from the seltzer water and the ability to be able to add the artificial sweeteners to make his own soda much more than he enjoyed the fizz from the Coke. And that was our first step towards getting his A1C under control. And within 3 months, his A1C went from like an 11 or 12 or whatever it was to like 7 or 7.5, which was without any medications, just getting rid of that one intervention alone. And then we made other interventions as well. He started, for example, having mashed cauliflower instead of mashed potatoes. He started having cauliflower rice instead of regular rice. Small changes with his diet, but he was able to get his A1C under control, and we didn't have to go into insulin just by making some small tweaks to his lifestyle regimen.
Whereas in a fee-for-service environment, you might often get a physician that just writes a prescription and patient leaves and is not able to take the time to actually work on some of these more impactful behavior changes than others, like you guys.
I can tell you. Oh, we got Victoria here. Victoria here was my first center manager when I left residency and I joined the Community Health Center in Tampa. Victoria, thank you for joining. And Victoria knows that even as hard as I would try in the fee-for-service world with the diabetics, especially with diabetic management, I felt like a good doctor when I saw the diabetic and I would tell a diabetic, hey, no sugars, no sweets, no sodas, no rice, no bread, no pasta. And then I pat myself on the back like I'm such a good doctor telling this diabetic that the diabetic would go, I'd refill their meds, and they'd move on with their lives. It's much more impactful to become a coach and work with the patient to set realistic goals and expectations between the doctor and the patient, and then you help them get to where to a place where it'll be beneficial for them.
Right. And Faisel, I think this brings us back to where we started here with moving upstream, is we can simultaneously improve medical services, healthcare services to patients in the same way that you have sort of begun to address some of these more impactful factors. At the same time, we can sort of advocate and try and sort of push for sort of more societal level interventions that address lifestyle behaviors and social factors. And I think that those combined approaches, while we're still able to use the medical system to try and change the way that we deliver care, instead of just writing prescriptions, it's about sort of these behavioral changes. It's about sort of meeting the patient where they are. It's about changing the mindset of how physicians and healthcare providers interact with patients. But at the same time, some of these larger scale, more sort of national systemic interventions are really important. And one of the things that I saw the other day is that Singapore has partnered with Apple. And so Apple Watch users who sort of adhere to a fitness plan that's tracked by their Apple Watch are actually paid to do so for anybody in the country by Singapore government. And those are the types of interventions and things now that we have technologies that we can do to sort of incentivize and to sort of promote some of these more upstream interventions for patients across the whole population. So it's a combined combined effort of both the medical care system and the healthcare system, and sort of us doing things from a public health perspective.
I love it. I love it. I love that this type of data is being relayed to the patients, and I love that just in general we're moving forward in this direction with looking at our health through technology as well.
Yeah, I think that lots of good things are coming down the pipe for virtual care, for the use of digital health tools, to be able to start getting towards the causes of the causes. But at the same time, it's very important that we also start to make sure that we're advocating for the social determinants of health, as we've discussed in previous episodes, that are also extremely impactful when it comes to the formation and the actual development of chronic illness in the population, as well as exacerbating existing conditions.
Robert, for next week, how about we talk, the topic should be around behavioral health and the impact of behavioral health towards primary care, and really how we could integrate primary care into behavioral health and behavioral health's integration into primary care. What do you think about that?
I think that would be fantastic, Faisel. I think that's another one of those areas that is really growing in movement, and that can have a lot of really positive outcomes for patients. So let's do it.
Let's do it. Well, thank you so much for joining us. We went a little bit over this week. We had some technical difficulties. You had to just put up with seeing my face instead of mine and Robert's. Thank you so much for joining, and we hope you found it informative. If you want to learn more about looking into the causes of the causes or moving upstream, you can always find great articles available at chenmed.com/resources. And we look forward to seeing you again next week. Thank you so much.